specific examinations, you'll construct those um, on Canvas in the home tab or on the home tab. Let me see if I can make that a little bit bigger for y'all. Looks a little bit too small for me. On the start here, make sure you go through all of these sections here, especially this practice quiz. No problem, Miss Natalie. Right here under information, we have a RadTech Bootcamp instructions PowerPoint presentation. Follow the steps in it. Keep in mind that the presentation was made with an older version of Cloverleaf's RadTech Bootcamp, but the instructions are essentially the same. And for these 4 exams, you'll build 100 question examinations for each of the content specs. So the first one you'll build will be for patient care. So all the questions will just be related to patient care. You'll take the exam that you build. It's not the assessment at the end of all the sections and all that. If it says assessment on it, that won't count. You have to go in and actually build an examination of 100 questions. Take a screenshot of that and upload it into onto Canvas for credit for that. Those are 10%. Then we have 4 comprehensive checkpoint tests. Um, these tests are 200 questions in length. They cover everything, all sections. There's not one section that's going to be way more. So, like the first one is in 2 weeks. We will do patient care tonight. And then next Monday, we'll have our safety, the first lecture of safety section. Um, and so that very first comprehensive checkpoint exam is not going to be specific to patient care in the first section of safety. It's covering everything. Um, you have a final comprehensive. Oh, I'm sorry. Those 4 every 2 weeks will count as 10% of the grade. Then you have a final comprehensive examination, which will count 10% by itself. That will be taken the Friday after the HESI. It will be available all of week 8. So you can actually take it before you take the HESI if you like. Otherwise, it is due, I believe, by the end of the day, Friday after your scheduled HESI examination, which is scheduled for Thursday. Now, the HESI will count for 30% of your final average. Attendance and participation. Of course, attendance is going to come from the chat that you've typed in your name for proof that you attended the lecture. That's only 5%. Now, there are 2 requirements that have to be met in order to pass this course. The first is that your conversion score on your HESI exam must be at least 70. If you do not pass or do not make a 70 conversion score, a 0 is recorded in the grade book, thereby ensuring that you don't make the calculated score required, which is an 80. So you can make an 80 on your HESI, and if you only make a 77 in the course, you won't pass. So you'll have to repeat it. The good news about that is your passing HESI score will count towards your next attempt, and you won't have to retake the HESI. If you don't make above a 70, I have to put a 0 in the grade book, and that will ensure that your course grade is below an 80, and you'll be required to take the course again. Late policy, no late assignments are accepted. I encourage you to stay on top of the work, stay on top of the due dates. The website on Canvas does have, if you go to the syllabus For the course summary, all the dates for all of the assignments and exams are listed here. Now your discussions, remember the first one, your very first post for a specific discussion is due on Wednesday, but all three of them are due by the end of day Sunday. Every Monday, I'll post an announcement giving you a little bit of a heads up of what's coming for that evening. I'll also post the link for the lecture for that evening. And then on Fridays, I'll do another check-in post or announcement just to make sure that everybody's still on track and doing their best to keep up. Now, regarding late work, I understand that there are things that, life is life and things happen. So if you run into a jam and you need to reach out to me, go ahead and do so. Typically have a way of working things out and making sure that everyone has a good opportunity to be successful in the course. So our grading scale, I don't believe, is any different from any of the other courses that you've taken in the program. Remember that the 80 is the minimum for a passing grade. These just spell out a little bit more of what I talked about for each one of the different sections. Now, for the content exams, the comprehensive checkpoint tests, except for the final, and the RadTech boot camp specific examinations are all graded on a sliding scale. So if on the first RadTech boot camp for patient care, you were to make an 82, I would go to this scale for the 80 to 84, where 82 would be there, and I would adjust your score to a 90. So once you get down to the 64 range, there's not a big jump in the scores. So you really want to do your best to be above a 65 in order to see any kind of a benefit from the slide scale. Any less than that, and you're not gaining very much ground as far as points go. Again, the comprehensive final and the HESI conversion score are not scaled. They will be recorded as is. And so this is what this says as well. If you don't pass, you don't make a conversion score of 70 or better, you will fail the course. As long as I've been doing this, which was October of 23, I believe. The examinations, I would encourage you to do only the one time and set the grade in, because again, here it comes down to a question of integrity, honestly, because if you're not doing well on the RadTech boot camps and you go ahead and pass your pad your grade, when it comes down to that final examination and that HESI, they're going to they're going to tell the tale of really how well you've been doing as far as the course goes and the content. So, if I suppose if you could live with yourself, go ahead and make another attempt with the examinations and then turn in your best one. But to me, I don't see the point in doing that at the end of it all. Plus, there's only 4 of them and they only count 10%. So you're really only losing 4 points if you get, or you're only gaining 4 points on your final average if you make 100 on all of those. Attendance and participation, of course, that's going to come from you typing into the chat your name at the beginning of lecture. You don't have to do it at the end. Also, if I do run long, you are able to leave without any kind of a penalty because it is going to be recorded. And of course, you'll be responsible for anything that was said after you left. Um, and participation, if you've got questions, I encourage questions during the lectures. You don't have to wait. You can type it in. I try to look at the screen and watch the scrolling chat to make sure that I don't miss anything. But if I do, just uh, take your mic off mute and get my attention, and I'm happy to answer any questions you may have. If you miss a lecture, um, instead of having to do, well, there's not a special section for it. So in the area for that lecture, where your grade would go on Canvas, go ahead and just submit a copy of your notes or a written summary. I will accept either one. A written summary of the notes, of course, is going to be a little bit longer. I would hope that you were taking notes during the lectures. Um, and so if that way, if you do, you don't need to reorganize them to put them in some sort of special format or anything. Just scan them in and upload them so that I have, uh, visual proof that you've written some notes from the lecture, and I'll give you credit for that. The lectures I will try to hold to 2 hours. So from 6:30, well, I actually try to do them in an hour and a half. Um, some of them do take a little bit longer. I try to be thorough, but I try not to hold you past 8:30 for sure. I don't try to hold you past whatever time it is I said. So, um, catastrophic events, again, contact me or contact Mr. Gage if you're more comfortable contacting him. He's really good about getting in touch with me if a student has a problem or needs some assistance. He'll let me know. If you do, if something major happens and you don't feel like you're going to be able to finish the course, please drop. Um, Fill out the schedule change form and officially drop the class. If you do not do that and you stay in and active on the roll all the way through, I have to assign zeros for the things you don't complete. You get an F, and that counts as an attempt in the class. So I believe you have limited number of times that you can take a course. Um, so you definitely don't want to lose out just because you didn't drop that course yourself. The online examination policies, make sure that you are going to be using the Respondus uh, browser. Make sure you have a good web camera. Make sure that you are plugged in. I don't recommend trying to take these tests on the phone, especially if you're driving. Please don't do that. Um, get somewhere quiet um, with a solid internet connection before you sit down to try to take these exams, okay? It's going to be very important for you. Um, because of the slide scale, there is no means of extra credit. Since we're already curving uh 70 60% of your grades anyway, um there's no way to make anything extra from what's already there. So, work hard and do your best. Um Again, you are going to have to use the Respondus lockdown. That system records everything, so be careful. Make sure you wear clothes. Make sure you read through this. You'll have access to a scientific calculator through the browser itself. If you've got two monitors, turn off one of them. Remember that it is checking your movements as well, and it can flag. Make sure you have an ID with you. Turn off music, TVs, etc. Oh, let's see. You need to make sure you're alone. Don't try to babysit the kids. If you've got kids, you can't get it that day. Let me know and get it. Take it ASAP. Uh, it's really bad to get behind. And yes, we did have this in here. Please be dressed. If you are a student with a disability, learning disability of any sort, remember that at a post-secondary institution, you must self-identify. So if you need any accommodations, make sure you get in touch with the school and request those accommodations as needed. I don't know how they always manage to put an old calendar in here, but they do. So the current calendar, again, is under the syllabus page on Canvas. These are all links here. So if you're worried about hitting something like the syllabus acknowledgement, you go ahead, make sure you hit that. It's a little, um, it doesn't count for a grade or anything, but you go through that and there should be a few questions here that you'd have to take, 6 of them. So just answer these questions and that'll satisfy the syllabus acknowledgement that you've looked through it. Again, for the discussions, they're for each one of the lectures. Again, I think about integrity, especially if you've had if you've been in the course prior to, this is a repeat term. I do read all the discussions. I do know if something's been repeated. So do your best not to copy and paste from a previous attempt into your current one. Give me some original thoughts on these discussions from those days of those discussions. Um, that is a really good question about the blank piece of paper. Let's see here. Go right back to the syllabus and see. I don't think anybody's asked about that. Yes, you may have a blank sheet of paper and a pencil, and you must show both sides. Um, I do not believe you can use your own calculator. I believe you have to use the scientific calculator through the browser. Problem with that is we have, the graphing calculators are capable of storing data in them, and make sure you don't have a access or resource of that type. Good question. Thank you for asking. Does anybody have any other questions about the syllabus or anything I've talked about up to this point? Okay. Here.
Recording stopped.
Go ahead and get rid of that. I'm going to keep the web page. Oh, there is one other thing I wanted to show you. And I'll do that with the next recording. This. Okay, so patient care.
Recording in progress.
So this is the first section we're going to worry about and work on. This is only one lecture. There are quite a few of these slides that do have some redundant and repeat information. I don't think it really uh, indicates the importance of that information. I believe that it's just being presented in a different format on the slides, making it easier for you to use for notes. So what should you study? Use the breakdown of the content areas provided by the ARRT. Focus your study process on those areas. Look at the weighting and the number of the questions. So for this here, if you go to, there is a tab on the on Canvas for this. It'll take you right to it. On the home screen, the ARRT content specifications under information. If you click on this, it will take you to the specifications. So right here, it tells you the content category. So this is how many questions will be regarding these different sections, the 4 sections on the registry. You can see procedures has 66 questions, image production with 51, safety with 50, and patient care has only got 33. Now, specifically, what do you need to learn? Under patient care, the very next page, it goes through each of the different areas that are going to be covered or have the potential of being covered in the examination. So this is your checklist. If you can go through this demonstrating or feeling confident that you know what needs to be known about these things, then you're good. Same thing for safety. They have one for each section. Okay. And I'll show you this again when we get into the procedures because it's longer. And so you'll definitely need one to be familiar with that one. So with our, sorry, patient care, there are only 33 questions and they break down in this fashion here. 4 of the questions will be over legal and ethical aspects, 5 over interpersonal communications, 5 over infection control, 4 over physical assistance and monitoring, 5 over medical emergencies, 3 over infection control, handling and disposal of toxic materials will be covered in 4 questions and only 3 questions in pharmacology. And I think that the last 2 slides of this presentation are a list and where it's a chart of the different medications and pharmacological items that you would be tested on. Okay, the DRG manual for doctors and nurses is pretty thick. There's a lot of medications out there, but the chart here um, presents those that are most commonly asked about. So going into the ethical and legal aspects, um, one of the most important things we need to remember is that consent is required before performing any radiographic examination. This can be verbal, written, and implied. Now, your basic consent, once a patient comes into a hospital, typically covers all routine non-invasive procedures, lab work, x-rays. I don't know why we have urinalysis separate because that to me just falls under lab work as well. Maybe it should say blood work in your analysis. So these, we don't have to have any kind of a special sit down with the physician and the patient for these types of procedures. Remember, they're considered routine or non-invasive. And for non-invasive, I pretty much remember that if we have to breach the outer layer of skin for any reason, or retrograde uh, any organs with contrast or fluids, or ingest contrast or fluids, then implied consent or your routine consent will apply here. No need for informed consent. So for this type of consent, the doctor, x-ray technologists, staff members, translations need to be, any type of consent at all needs to be done with in the patient's first language. Mr. Norman, I believe it's a 75 overall. So, and but again, because they weigh differently, it's not a hard percentage. I don't know if that makes sense. Informed consent is different than that basic consent or implied consent. Informed consent is going to be required for a procedure that is considered experimental or carries a substantial risk. And again, these are all things that are going to require uh, either the injection of contrast or the introduction of contrast in the body, or, as I said, a breaching of the skin. For an informed consent, a physician is the only healthcare professional who can legally obtain an informed consent from a patient for a procedure. The ordering MD should uh, not get a patient's consent for a normal radiographic or a routine radiographic procedure. Okay. They basically just write out the order, give it to the patient. The patient brings it to us. And with them presenting it, saying my doctor sent me over, or I need to have this test done, or whatever, that's an implied consent. Implied or presumed consent also uh, covers emergency situations when the patient's unconscious, if the patient's incompetent, or there's no one else that can give consent uh, for the procedures. In these instances, the doctor performing the procedures will assume a much more significant risk because the patient was not duly informed. But it is a special consent um, or a special situation. And like I said, implied consent, just them coming to the department and saying, "Hey, the doctor sent me for a chest X-ray," and giving the order to whoever it is at the front desk, is implied that they want to have that done. They understand that there, is a small minor risk, and they want to have the exam done. The big difference is with a surgery, you could die. Having a chest X-ray, the likelihood is extremely low. Now, in order for an informed consent from the patient to be valid, um, they have to be of legal age. They need to be of sound mind. Their consent must be freely given, and it must be given after they are adequately informed of all risks and sorry, lost my train of thought there. They have to be adequately informed of the procedure itself, everything that's going to be taking place during the procedure. Um, from how big of an incision, where the incision is going to be located, all that stuff has to be spelled out for them. And then, of course, any risks. Um, they also have to be informed of any alternative means, and the possibility, asked if, okay, we're going in for an exploratory, but if we find something, this is what we're going to do. Do you consent? Are you okay with us doing that? Or is there something that you don't want us to do? I had a knee injury several years ago, and I went in for an arthroscopic ACL reconstruction. We already knew the ACL was blown, it was gone, but we had an agreement, and the doctor and I talked. If there was anything else that was in there that he could fix or take care of or needed attention, did I want him to continue with that or just do the repair? And of course, I opted for all of it. And when you know it, I had a torn cartilage as well. So um, being adequately informed and educated is very important for an informed consent to hold. Looking at the patient's Bill of Rights, healthcare providers must adhere to these 12 rights, um, always making sure to give considerate care to our patients, understand that the patient has the right to be informed, also to refuse treatment. Uh, good example of this is if they feel like they're claustrophobic and they try to have it without any type of sedation, they try to have an MRI without any type of sedation. Um, they could go 3/4 of the way through the procedure and then decide that they can't do it anymore. The it's become too much for them to bear, being in that little opening or in that little tube, stuck in that cramped space. And so when they say, I'm done, I can't do this anymore, then we are obligated to stop the procedure. They have the right to an advance directive and the right to privacy and to have their confidentiality maintained. They do have a right to review their records. Now, the records themselves do not belong to the patient, but the information contained within those records, they have every right to. They do have the right to request services, with the exception of specific procedures or examinations, especially where X-rays and radiation is concerned. Um, they have a right to be aware and made aware of any business relations and relationships that they're in. They have the right to informed research, continuity of care, and a copy of the hospital's policies. Procedures that require the written consent. Um, this is informed consent. The date of procedure, the name and explanation of the procedure, the name of the physician performing the procedure, a list of all possible side effects and risks, then the patient's signature or the signature of their proxy. An advance directive allows patients their autonomy and informs healthcare providers of their wishes if it comes to life-saving or heroic measures. Living will is a type of advance directive, identifies specific healthcare requests, and it should recognize an individual to act as a proxy for the patient. DNR is the acronym for do not resuscitate. A DNI is for do not intubate. So here's some of the terms. Autonomy, the right for individuals to make decisions about their lives and their own health care. Beneficence is an ethical principle in which all acts are intended to cause good or provide a good outcome. Confidentiality deals with information privacy. Civil law is the law that regulates relationships between individuals, and it is important to know because most of the medical lawsuits that occur are going to be civil lawsuits. There's not often that we find a criminal lawsuit involving uh, healthcare. This also falls under the next subdivision of civil law is tort law, where the civil injury or injustice occurs. So E is part of D. It's a subsection. F is one that people get confused. They misuse this term quite frequently in general population, but assault is a threat of bodily harm. It is not actually the physical harming of an individual. That is a different thing. Assault is the threat of the bodily harm, where an individual feels fearful for their well-being. Okay, is when a threat is made that causes an individual to be fearful of their well-being and their health. That is an assault. Battery is this says bodily harm, and yes, patient gets punched in the nose, they were battered. However, legally, battery includes any unwanted touch from another individual that the recipient feels threatened by. So just the simple, I told you not to do that anymore, finger poke in the chest, that's battery. Even if they don't even leave a red mark, don't even leave a bruise. You didn't draw blood. The patient, the person didn't fall down. You touch them. They didn't like it. That's battery. False imprisonment is keeping someone against their will. Remember, in radiology, we immobilize. We do not restrain. False imprisonment includes a restraint or an unlawful restraint of a patient. And remember that um, restraining a patient must have an order from a physician accompanying it. Slander and libel are two types of defamation. Slander is spoken, libel is written. Defamation itself is when someone, at the definitions on the next slide, I'll need to rearrange that so that it flows better. Negligence is a breach of duty that causes an injury. Malpractice refers to negligence, but it is negligence can be accidental. Malpractice typically isn't. So defamation of character, undermining an individual's person, or speaking ill, or holding them to ridicule or scorn in a respected population or community. And again, it can be slander spoken or libel written. Again, it does not have to be false. Whatever it is that's being said, it just has to be being presented in a way to damage another individual's reputation. Even if it's true, even if it's truthful, it can still be considered defamation of character. Intentional torts, premeditated, thought went into it before it was performed. Um, Unintentional torts are accidental. They're typically the result of other actions that were not and were not meant to cause harm. With legal doctrines that come into play during negligent tort cases, res ipsa loquitur, as this thing speaks for itself. This basically holds that an individual or a patient was harmed while in complete control of another individual or healthcare worker. Um, this is something that comes into play quite frequently for um, negligence cases. You know, if the transporter had locked the wheelchair, then the wheelchair would not have slid out from under the patient and when they fell and struck their head on the floor. That would be res ipsa loquitur because obviously transporter is supposed to be taking care of the patient. If the patient's holding them and they drop them, that would be res ipsa loquitur for sure. The respondeat superior is another legal doctrine that comes up in these negligent tort cases. The master speaks for the servant. This is why, whenever there is a medical negligence case that comes out into the public domain, you never hear about the technologist or the nurse. Sometimes you don't hear about the nurse, the technologist, or the uh, hourly wage earner being sued for so many thousands, hundreds of thousands, or millions of dollars. It's typically going to be the owner of the facility or the corporation that owns the hospital, right? And so with respondeat superior, the master speaks for the servant because the corporation hired all of these people to run the business, and then these people hired specific individuals to do the work. Ultimately, the corporation is responsible for the little guy at the bottom of the ladder. And so that's what uh, this kind of charges corporations and big companies to really vet their employees and make sure that they're getting the highest quality uh, employee. Because if not, whatever it is that employee does, good or bad, reflects and will be answered to by the corporation or the owner. Now, for HIPAA, uh, remember this is uh, Health Insurance Portability and Accountability Act. I think it came about in 1993, 1990, I think it was 93. The legislation was designed to promote uh, portability of the patient's health records and ensure consistent, informed care for all providers. That's what HIPAA was initially designed for. But at that time, the internet was very, very young. Uh, Email extremely slow, internet connections were slow. So we were still relying on some of our older technology, specifically fax machines, answering machines at home, taking messages and that sort of thing. So it became fairly evident right away that privacy was going to be a problem. You get two numbers mixed up in a fax line, it goes to the the ice cream store or whatever, and now somebody's health information is in the hands of an individual that it does not belong in. So while coming up with this method of making your information portable for easily moving between providers, uh, they uncovered the privacy issue, and so it got hammered down, and it covers all healthcare information about the patient, whether it's electronic, paper-based, or even spoken. Now, the ART, the American Registry of Radiologic Technologists, maintains the standard of ethics for our profession, and the ethics are divided into two parts. The Code of Ethics, which is aspirational. There are 11 principles in the Code of Ethics, and they apply to different areas of our job and our profession. And again, they are aspirational. They want us to try to stay faithful to those 11 principles, understanding though that it may not be possible at all times. The rules of ethics, however, are not aspirational. You have to abide by the rules of ethics. The code of ethics, we work towards making sure that we are within those. But the rules of ethics are very, very specific. And just with you as students wanting to take the registry examination, you have to sign that you are willing to and will comply with the rules of ethics as well as the code of ethics. And there are rules pertaining to um, continuing education. You have a group of technologists, they all work at the same place. They may buy or purchase some sort of continuing education module or whatever. They get the test, they get the answers, and then they pass that test on to another individual who registers using somebody else's work. That is against the rules of ethics. You can get sanctioned for that sort of thing. So, before you definitely sit for your registry, make sure you run through these again. Make sure you run through these again. I tell this to all my students. We do this in the intro class I just finished this summer with my program, and I emphasize to them going through the standards of ethics and the standards for and from the ASRT. Negligence litigation connected with the radiography department, usually associated with one of the following causes or situations: pregnancy, if the patient falls or is injured in another way within the department, delays in the diagnosis or errors in the diagnosis. And it's estimated that roughly 10% of all negligence cases originate from the imaging department. But while that doesn't sound like a lot, I mean, 1 out of 10, once you start talking about hundreds, 200, 300,000 cases, 10% is quite a bit. Now, the elements that must be present in order for someone to successfully win a negligent tort case, there must be a breach of duty between the prosecution and the defendant. Okay, so that patient, there had to be duty for that tech to that patient. It has to have been defined and agreed upon uh, prior to the interaction. Then they have to prove that there was a breach of that duty. Then they have to establish that the patient did, in fact, sustain an injury and that the injury is directly related to the breach of duty. Now, once we get to this point here, I know you're all familiar with innocent until proven guilty, right? Especially when it comes to criminal stuff. Same thing applies here through A, B, and C. But once we get to D, the burden of proof shifts and it switches. So A, B, C, you're innocent until proven guilty. Once we've gotten these three established and we get to 4 or D, then it becomes the defendant's job to prove that they were innocent and they did nothing wrong. So one of the instances in which that occurs. Any questions about legal aspects? All right, moving through here. Interpersonal communication. Most of our communication with our patients is going to be verbal, right? This includes using the appropriate eye contact, speaking correct language for that patient, the speed at which you speak, the volume and pitch that you use while speaking, and also allowing room for the patient to ask questions. Um, Nonverbal routines or nonverbal routes include your facial expressions, touch, and just overall general attitude while interacting with the patient. The better our interpersonal communication, for the most part, the better the examinations will go, the easier it is to get the patient to comply and follow directions. Another important part of this is being able to obtain a patient history. Remember, we are the eyes and ears of the radiologists. They get the images that we take, but they don't get the context in which they're taken and all the time, because when I started in school and I started in the profession, we worked side by side with the radiologists. We talked to them frequently throughout the day. We interacted with them, before, after, and sometimes during examinations. And it's not that way anymore. Radiologists, pretty much stay locked away in their reading rooms, and only specific technologists ever go talk to them or call them on the phone and disturb them. Um, but and because of that, it has become even more important for us to be able to take a good patient history. Remember that we're going to need objective and subjective data to go along with that. Objective data is anything that is uh, or can be measured. There's a quantity that's going to be applied to that data. If it's subjective, then it's more or less about how the patient is feeling. Um, you can quantify pain on a pain scale. If you give them a pain scale of 1 to 10, 10 being the worst, where do they feel like their pain is? They can give you a number, that's a quantification. Um, if the patient's feeling nauseous, that's not something that you can measure. And people are more tolerant of stomach problems. Some are more tolerant than others. And so the level of nausea in one individual may not be the same severity wise as the level of nausea in another patient. So that's going to be more subjective type information. You can see bruising, you can see swelling, you can measure lacerations. You can hear grinding or popping or snapping, those types of things. So all of that's objective. Um, You need to ask your patient open-ended questions. This is going to force them to elaborate, um, avoiding that closed yes or no type of thing. Now, granted, there are some things that you just need a yes or no answer for. We're not saying don't use closed-ended questions all the time, but just know that for some things, a yes no response does not give enough information. Avoid using leading questions. Don't try to uh, suggest anything or information we need to be able to provide some education to our patients, be able to tell them in layman's terms the type of exam they're doing, what they're going to be expected to do, how long it should take, the type of equipment that'll be used, any post procedural type of instructions. One thing I go through with my students is they try to be polite. And that's one thing I notice about, especially the first year when they're just getting in, just getting into clinic and dealing with patients, is they tend to ask patients to do things for them. Can you stand up and put your chest against the board? Can you put your hands on your hips? And I try to steer them away from that, because one thing that we don't want to do uh, in this situation when we're dealing with our patients is give them an out. If they want out, if they don't want the exam, they should say, I don't want the examination. But otherwise, if they're there and they're proposing to have the examination, I need them to do things for me. I'm not going to ask them to do them. I'm going to inform them that I need them to. I need you to place your chest up against this board. Um, Palpation, hands-on approach. Grabbing the wrists. I need you to turn your hands and put them against your hips and roll your shoulders forward for me. That way they don't have the option to say no, and you're being very, very clear about what it is that you need. And you can do that without being rude. You should have a good working knowledge of all the other different modalities involved in the imaging department. Being able to give at least a little bit of a description of these types of things, knowing that MRI and sonography do not provide any type of ionizing radiation, knowing that bone densitometry uh, typically involves a lower dose of radiation. They're very, very quick. There's not a lot of movement that goes along with those. It basically lies still. Moving into our vital signs. This is where our slides get a little redundant, but that's okay. The four common vital signs, of course, being pulse, blood pressure, temperature, and respiration. Normal levels. For blood pressure, the systolic measurement deals with the contraction phase of the heart. The diastolic measurement deals with the relaxation phase of the heart. So the systole should be anywhere from 100 to 140 millimeters of mercury. Diastole should be anywhere from 60 to 90 millimeters of mercury. Temperature, normal temperatures, 98.6 degrees Fahrenheit. Respirations for adults, anywhere from 12 to 20 breaths per minute. Children, up to 30 breaths per minute. For the pulse, we have our three different ranges there. For adults, 60 to 100. Children, 70 to 120. And infants, 100 to 160. Blood pressure should be measured with a sphygmomanometer. Your systolic is your top pressure, the working pressure of the heart. Your diastolic is the lower number, the resting phase of the heart. Blood pressures above 140 over 90 are said to be hypertensive. So the patient has hypertension. Blood pressures below 90 over 50 are said to be hypotensive. Remember, the prefix hyper is above, hypo prefix is below. Temperature measurement, most common method for adults and cooperative children will be orally. The tympanic through the ear is preferred when unable to obtain oral. The axillary takes up to 10 minutes to obtain, so the thermometer has to sit there for quite some period of time. It's the least accurate of all locations to take temperature. And then, of course, rectal is another method when unable to obtain an oral temperature. Respiratory terms, tachypnea is rapid breathing, so in excess of 30 breaths per minute. Bradypnea is a decrease in that respiratory rate, with dyspnea meaning difficulty breathing, and apnea being the complete absence of spontaneous ventilation. They're unable to, the diaphragm's not even moving to breathe. We'll see those prefixes again. The pulse can be listened to with a stethoscope and can be felt At 3 superficial arteries, the radial, brachial, and the carotid. For the most accurate reading, should be palpated for a minute. The adult rate, again, 60 to 100 beats per minute. Children under the age of 10, anywhere from 70 to 120. Tachycardia, in excess of 100 beats per minute. Bradycardia is a slowing of the heart rate. Keep in mind that hypothermia can cause bradycardic presentation, and athletes can also present with a decreased heart rate below the normal. Um, Athletes, swimmers, uh, scuba divers, distance runners, um, soccer players, those types of activities where they do a lot of running, a lot of cardio, those athletes can have blood resting heart rates well below that 60. I ran cross country in high school. My resting heart rate my senior year was a 42. So, you get into good enough condition, especially pro level athletes. Don't be surprised. Again, make sure you get a good history. You know what it is that if you find out the heart rate's a little below, find out what it is they do. Maybe they are an athlete. Maybe they present as an athlete already. So you have a heads up there. For our physical assistance and transfers here, there's a couple here that are, let's see, I think I saw one. I know there's one resource that says that you should push heavy objects, not pull them. For us and our good body mechanics, we're going to pull the heavy objects to us. We're not going to push them away. Make sure you bend your knees if you're going to lift something. Balance your weight on both feet. Don't lean. Pivot on the balls of your feet and your heels. Don't twist in your torso. Hold the objects as close to the body as possible. This reduces the strain on your core, specifically your lower back. Keep your feet should be shoulder width apart. That allows you good balance, and bend your knees. Keep your back straight. Again, don't twist your body. Don't allow the patient to grab you around your neck. And very, very importantly, listen to your body. Stop if you feel a strain. Return the object, return the patient from whence they came. Do not try to continue if you feel a strain, because the back injuries are very, very difficult to recover from. Neck injuries too. Oops, sorry. Back a slide. Patient transfers can include ambulatory patients, wheelchairs, stretchers. Infants should be carried, and whoever's carrying them should be transported in a wheelchair. We don't want them falling. When dressing and undressing a patient, remove the arm from the unaffected side first. It is much, much easier for them to manipulate and move the unaffected arm around. Once it's loosened, the garment then is easier to just pull off the affected side. When putting a gown on or redressing the patient, start with the affected side, the one that's difficult to move. That way, all the movement's done with the material, and then have the ambulatory get in. Moving into infection control. CDC should actually be these are our infection control. It's our glossary, if you will. So CDC, Centers for Disease Control, pathogens or microorganisms that cause disease, antisepsis, the process that retards the growth of pathogens. Disinfection, however, is the destruction of pathogens. Medical asepsis is the removal of pathogens through disinfection. Surgical asepsion or sterilization is the complete removal of all microorganisms and their spores. Fomite is a contaminated inanimate object, a tabletop, a chair, an armrest. A vector is an insect or animal carrier. Vehicles are food and water sources of the pathogens. Direct contact involves person to person, person to touch, or to the body fluids. Indirect contact is when the pathogen is transmitted without human contact or interaction. Bacteria are one-celled organisms. They contain DNA and RNA. Viruses are the smallest pathogen, and they contain either RNA or DNA. They never contain both. Fungi are yeasts and molds, parasites, protozoa, and parasitic worms. PPE is the acronym for personal protective equipment. Disease transmission can occur by direct contact. The involvement of a fomite vector vehicle all constitute indirect transmission. Airborne contamination and droplet contamination also involve indirect transmission. And remember, an airborne contaminant is something that can move through the air on its own. It does not have to be on anything. Droplet contamination is when the droplets hit surfaces or travel through the air and the disease is attached to the droplet. Nosocomial infections are acquired during the course of medical care. Iatrogenic infections are contracted as a result of a specific treatment or procedure. So with infection control, the transmission type here on this chart, the airborne, droplet, or contact, the description of that transmission, the different pathologies, and precautions required for those different infections. Good chart to make flashcards from. Hand washing is the most important component. Run your hands under water and apply soap for a minimum of 20 seconds with friction. Faucet open and closed with paper towel. The hands and wrists should be lower than the elbow. This is so that when anything, if any of them does travel this way, they don't get up into your sleeves and up into your elbows. We want them dripping off the ends of your fingertips. Your surgical scrub, however, requires a minimum of up to 3 minutes. Up to 5 minutes, minimum of 3 minutes, up to 5 minutes. The hands and wrists should be higher than the elbow. And we're going to use a brush to go along with that to perform the scrub, starting at the fingertips, working our ways back down this way. Now, rinsing is done the same way, fingers up, water comes down towards the elbows. That way, everything runs this way. All of this surgical antiseption and sterilization has happened here at the fingertips, and gravity is pulling all the waste this way. Now, they do dry. Use a towel, right? Working their way down this way. But if anything is not complete removed, most of the time it's going to be removed from the hands and fingers. Anything that comes here will be under the gown. And the gown rarely gets cut. It rarely tears open. Gloves, however, do. So if you have any microorganisms or spores left from the scrub on your fingertips and the glove rips or tears, then there's a possibility of exposure and contamination of the surgical field. By doing the scrub this way, if there is a tear, one simply has to re-glove, because any danger of that sort of thing, spores and microorganisms, would be concealed under the gown. That's why we scrub that way. Now, protective or reverse isolation is going to be used for patients who have weakened immune systems, burn patients, transplant recipients, and patients with leukemia. Our infection control, including the donning and doffing. This is the correct order from top to bottom of putting on the PPE. First, wash your hands, put on a cap, put on a mask, then your gown and gloves last. For removal, take the gloves off first, then the gown, then your mask, cap, and then wash your hands. Sterilization is a complete removal of microorganisms and their spores. Steam is the quickest and most convenient means. It costs less, but the items have to be able to withstand the heat and the moisture. We don't want them rusting either. After steam, chemical sterilization, gas ethylene, and gas plasma. Needles. Do not recap your needles. Leave the needle attached. Dispose of the whole syringe into the sharps container. Here's our cycle of infection. Remember that this does require an infectious organism, a reservoir of that infection. So there's got to be a source, a portal of exit from that reservoir, a susceptible host to receive that infectious organism, as well as a portal of entry to the to the host, and then a means of transportation of the organism from the reservoir to the host. I don't know why I want the horse infected today. It must be a thing. For physical assistance and transfers, make sure that we keep IV lines 18 to 24 inches above the vein. Any lower, the patient may not get the prescribed drip. Any higher could cause an increase in drip rate and an increase in pressure because of gravity. Chest tubes, the sealed drainage container must be below the chest at all times. Same thing for catheters, the bag must remain below the urethra. And for oxygen tubing, it must remain patent and free flowing. Spinal injuries, log roll if it's necessary to move them or roll them. Patients with splints, make sure that we support the entire extremity, both above and below the site. Same thing with suspected fractures. Medicated and sedated patients should not be left alone or made to stand erect without support. For medical emergencies, in this section, understand that oxygen is considered a medication. It must be administered only with a doctor's order. Oxygen toxicity can occur and lead to death. So we need to be very careful with our O2 administration. The nasal cannula is the low flow device, simplest and most frequently used if the patient's got long-term oxygen administration. This is less than 5 liters per minute. That's the flow rate. Typically, there'll be a container of sterile water in line with that. That is to moisturize the air to keep the mucous membranes from drying out and becoming damaged. A simple face mask can be used, covers the nose and mouth. This is typically for short-term therapy. The O2 concentrations can vary from 40 to 60%. Then we have the non-rebreather, which has a bag that fills with 100% oxygen and a valve to prevent exhaled gas from being inhaled again. Then we have a rebreather, which is another low flow method. And then, of course, the ventilator, which is the mechanical respirator. This is a high flow device. It is powered by compressed air and it controls the rate of respiration, the amount of air by volume, and the oxygen content of that air. For medical emergencies, again, redundancy here, these are the ranges for normal. Anything outside of these ranges would constitute an emergency situation. Just again, reiterating information here. I find that these are good resources for um, flashcard construction. Aside from the three that we measured, we talked about earlier, the radial, the carotid, the brachial, which isn't listed here, surprisingly. We can also take the pulse at the temporal artery, the femoral artery, the popliteal artery, and the apical left anterior chest. Allergic reactions for allergies. This is an abnormal acquired immune response brought about by substances which usually do not trigger reactions. Latex, some proteins can cause mild to severe allergic reactions in individuals. Again, patient history, good communication. Knowing that equipment like gloves, tourniquets, IV tubing, syringes could contain latex, or knowing whether or not they do contain latex is definitely something that you'll want to be aware of. If a patient is diaphoretic, they've got cold, clammy skin and they are sweating profusely. Cyanotic, got a blue color to the skin and the lips from the lack of oxygen. A malaise is a general feeling of unwell. I just don't feel good. Hypovolemic shock is the shock that results from significant blood loss. Septic shock results from a systemic infection. Dyspnea is difficulty breathing. Orthopnea is difficulty breathing while recumbent. I'm sure you've run across those patients. They can't lie flat. They got to have their head elevated. They can't breathe. That's orthopnea they're suffering from. We have orthostatic hypotension is when we have the sudden drop in blood pressure upon, from a lying position, sitting up, or from a seated position, standing up. Bradycardia is when the heart beats at a rate less than 60 beats per minute. Tachycardia, greater than 100 beats per minute. Fever is an increased temperature, typically indicates an infection. Then we have anaphylactic shock. This is a result of a hypersensitivity to a substance. Hyperglycemia. Okay, hypo is below. Okay, below. Glyceme is Latin for glucose, and glucose, of course, is sugar. So hypoglycemia is low blood sugar. So when the glucose level falls below 50 to 60 milligrams per deciliter, it means we have an excess amount or an increased amount of insulin in the body, but the blood sugar is low. Okay, so hypoglycemia. Diabetic ketoacidosis is when we have an insufficient insulin that results in increased or high blood sugar. Okay. CVA, cardiovascular accident. It's a stroke. Looking at needles and catheters. Gauge identifies the size of the needle's bore diameter, so the hole in the needle. What's the diameter there? That's going to be told by the gauge. As the gauge number increases, the gauge size increases, the needle bore gets smaller. All right, so a 14 gauge is a larger bore than a 23 gauge. Okay, the bigger the number, the smaller the bore. It is exactly the opposite with catheters. And we don't call them or refer to them in gauges, we refer to them in French. And this is the outer diameter of the catheter. So again, as a 25 gauge is going to be smaller than a 16 gauge needle, but a 25 French catheter will be larger than a 16 French catheter. Moving into contrast agents. Contrast is going to change the absorption properties of whatever tissue that contrast is being contained in. Room air is used in barium enemas to help distend the bowel so the radiologist can get good visualization of the mucosal lining of the colon. This is a negative contrast agent. Effervescent crystals that we use in the upper GIs also cause distension of the stomach because it's releasing that gas. That air is easier to penetrate. Therefore, it is a negative contrast agent. It reduces, it lowers, it subtracts from the tissue's ability to absorb X-rays. Okay. Positive contrast agents, such as barium and iodine, do the opposite. They increase the absorption properties of whatever tissue they're contained in. So they're going to appear lighter in our film or in our images because they're going to absorb more X-rays. They increase the brightness. That's another positive. Negative contrast agents decrease the brightness of our image. There are two types of radiopaques, soluble and insoluble. A soluble dissolves in the fluid or water, and most of the time it does contain iodine in some form, and it does not settle. When it comes from the manufacturer, the iodine, the soluble contrast is distributed evenly throughout the fluid. Okay. An insoluble is a contrast that doesn't dissolve in fluids. It can be distributed and mixed, but it won't stay there. It will settle back. If given enough time, it will settle because of gravity. So it's just temporarily suspended within the fluid. That's why we call it's a barium suspension that we use. So, contrast medias with iodine, you could have ionic or non-ionic. The ionic have a higher osmolality, and they have they have positive and negative ions. Non-ionic contrasts are less toxic. They have good miscibility, which miscibility is the ability for the contrast to mix in the blood. Whether it's ionic or non-ionic, they have the same ratio of iodine in them. The osmolality is the number of particles in a solution. The viscosity is the thickness of the concentration, or how well or how easily that contrast flows. Syrup, molasses, honey. Honey is more viscous than maple syrup. Water is less viscous than syrup. Okay, so it's all about the flow there. Suspension, it's mixed with water and suspended temporarily in the fluid or the water. Toxicity refers to the potential for a harmful effect. An infusion is contrast or medicine over a period of time. Bolus is a large amount of contrast or medicine given over a short period of time. If the medicine or contrast escapes the vein or vessel, that is an extravasation. Miscibility is the ability of the contrast to mix with the blood. The parenteral routes for medication administration include intravenous, intramuscular, intrathecal, intradermal, subcutaneous, topical, and vaginal. Other administration routes are through the gastrointestinal tract, oral, rectal, and sublingual. And you would think that because oral involves going through the mouth, that sublingual would count as an oral. The difference between an oral and a sublingual medication is the oral is absorbed by the lining in the stomach or the intestines. The sublingual is absorbed by the cells underneath the tongue. So the medication works faster underneath the tongue than it would if the patient swallowed it. Contraindications for using iodinated contrasts include sensitivity because of allergy, if they're diabetic on glucophage, an elevated BUN or creatinine, or renal failure. Multiple myeloma and sickle cell disease are also contraindications for iodinated contrast use. I'm noticing it's 8:07. If you need to leave, you can go ahead and do so. We have 9 more slides, so it shouldn't take too much longer at all. And again, the last 2 are charts, so uh, don't really have to look at anything for that. But I'm going to keep going. Make sure you signed in before you leave, though. Contraindications for using the barium sulfate. If we suspect a perforation in the GI tract, if there's fecal impaction or a sensitivity to barium sulfate. Very uncommon, but it does happen. Fecal impaction, even though we're using barium, especially if we're going in rectally, gravity is pulling that barium down into the patient. The force of that hitting an impaction could cause a breach. Okay, Mr. Norman, have a good evening. A tear or perforation in the GI tract would cause the barium to leak out into the peritoneal cavity, and that is a bad deal. Barium does not get absorbed by the body. It's the other reason why we don't use it for injection. The body cannot process the barium sulfate, and so it basically just pulls all the water out of it, and then it just turns into, a barium sulfate rock within the patient. So we definitely don't want it outside of the GI tract. As far as the sensitivity and the allergy, we used to mix up barium and have the students drink. I did when I was a student, drink the barium just to see what it tasted like. So we would have a little bit more empathy and understanding for patients going through upper GIs and barium swallows. And probably 20 years ago, 23, 24 years ago, we had a student um, that had a reaction to the barium sulfate. They had a sip and they had a reaction, and of course, cut that off. So no more drinking the barium on school time. Iodinated contrasts are typically administered intravenously. They can be given orally, though. The common sites are the anacubital, the basilic, the cephalic, and the accessory cephalic veins. Now, for venipuncture, these are the steps. They are in order. Okay, so they're not numbered, they're bulleted, but you have to go in the order that they're presented here. So gather your equipment, identify your patient, use two identifiers, please. Wash your hands and secure the tourniquet. Then put on your gloves, cleanse the area, hold the skin below the injection site, insert the needle with the bevel up and verify flashback, blood coming back. Then connect your tubing, release the tourniquet, and then inject. Reactions are identified with respect to the symptoms present as mild, moderate, or severe. Um, Mr. Vasquez, just type your name into the chat like you're going to send a message. Just type Jose Vasquez and hit enter, and it'll put you in the chat. And now I've got you as attending. So for the mild reactions, any of these can occur within 2 to 10 minutes post injection. So itching of the nose, the eyes, an increase in anxiety, cough, hives, and a rash constitutes a mild reaction. A moderate reaction, we have coughing from a laryngospasm and could be accompanied with dyspnea and some chest pain. Severe reactions include hypotension, dysphagia, dyspnea, seizures, and cardiac arrest. And an anaphylactic shock in the radiography department is an allergic reaction to iodine in most cases. Adverse drug reactions include nausea and vomiting for the minor, along with hives and urticaria. These are self-limiting. Calm reassurance can be very helpful, but it could be a precursor to a more severe reaction coming down the line. If medication is needed, typically an antihistamine, such as diphenhydramine, brand name Benadryl, is administered. Of course, this would be under the medical director of the imaging department. If the minor symptoms continue or worsen, we move into an intermediate reaction, which can include hypotension, respiratory distress. This case, they want to administer epinephrine and O2. If the symptoms aren't controlled by the epinephrine, we may move to a bronchodilator, such as aminophylline. Major reactions include shock, respiratory wheezing, edema, convulsions, cardiac arrest. Either could lead either way to tachycardia or bradycardia. Before administering contrast, especially iodinated contrasts, we want to have some lab values. For the BUN, the blood urea nitrogen level, how much nitrogen is contained within the system, 8 to 25 milligrams per deciliter is the normal range. The creatinine, which is more sensitive and better representative of kidney function than the BUN, you're looking at 0.6 to 1.5 milligrams per deciliter. If a patient's BUN is elevated above 30 and their creatinine is elevated above 1.5, then there is a renal insufficiency for that patient, and contrast most likely will not be allowed to be used for the study. And again, the last few slides here are the drug type, the effects, and examples of those drug types. This is the pharmacology portion here. So we'll run through those. Again, good slide. I mean, flashcard uh, building blocks here. Does anybody have any questions? 8:15, not too bad. Now, just because we get to talk and meet on Mondays does not mean that I'm not around. So send me an email. I have up to 24 hours to get a response to you. If I don't know the answer, I will definitely find out. Um, yes, it can be in both. Miss Leary. So we're having some distress in the intermediate reaction, but in the major, we're having some definite. For the 14th, yes, we will have lecture on the 14th. Again, I'll post an announcement. I'll send out an announcement Monday mornings, and then by Monday afternoon, at the very latest, I try to get it done at noon. Uh, Send out the invitation for that evening's lecture. Thank you for your attention. Thank you for being here. Y'all have a great evening too. Good luck. And again, if you have any problems or you need any questions answered, hit me up. I'm available. I'll do my best to help. Very good. Thank you.